Note, my topic is role of spectral domain optical coherence tomography in blunt ocular trauma patient, a cross-sectional study. So introduction in blunt ocular trauma damage is caused by direct contusive force or counter-coup injury, and the main causes are road traffic accidents, sport injury, physical assaults, workplace or home accidents. Traumatic maculopathy due to closed globe contusion can manifest as commissuretino, traumatic macular hole, indirect choroidal rupture, in retinal damage or pigmentary changes. And the aim is to evaluate microstructural changes in macula following blunt ocular trauma. And the primary objective is to evaluate these microstructural changes in macula following blunt ocular trauma. And the secondary objective is to evaluate the usefulness of SDOCT in blunt ocular trauma by assessing the early microstructural changes in macula. So this materials and method, it's a cross-sectional study which was conducted in Department of Ophthalmology and Emergency Medicine with 60 patients with blunt ocular trauma. And the inclusion criteria, patients with blunt ocular trauma who give informed consent and by obtaining high quality OCT images. And the patients with lens and media opacity and with traumatic glaucoma was excluded. So methods of data collection, 60 patients with blunt ocular trauma patients were taken and detailed history and examination was done, and OCT macula and RNFL, OCT RNFL was taken. So from this, the result was the distribution of patient according to sex is about 53% were male and 47% were females. And the distribution according to mode of injury, about 33% having RTA, and having those who have got blunt ocular trauma with object greater than orbitis was about 17%, and object less than of orbitis 50%. So in visual impairment, in this case 45 having with visual impairment and 15 having without visual impairment. And the frequency of macular changes were classified as foveal and extrafoveal. So from this, commercial retina has higher frequency. So this is the bar diagram showing that having commercial retina having 18 extrafoveal and 12 foveal cases. So rest having choroidal rupture, macular hole, retinal pigmental changes, and retinal detachment. And in this, I included traumatic optic neuropathy, having 10 patients. So these are the OCT pictures showing retinal pigment epithelial changes with ganglion cell complex loss and RNFL loss. So these are the pictures. And from all these things, there is a circumpapillary RNFL analysis. I have taken during presentation time, case and control I was compared, and there was a thickness CNFL RNFL thickness in the affected eye show reduction when compared with the contralateral control eye, but on statistical analysis it was not significant. So this is the bar diagram showing that. And also ganglion cell complex analysis also the same. There is a thickness is reduced when compared with contralateral control eye, but on statistical analysis it was not significant. This is a bar diagram showing that. And on discussion, commissuretino is the most common finding in the blunt ocular trauma patients. And OCT changes, we have seen there is a reflectivity of change in reflectivity of the retinal layers with variable increased reflectivity from the inner retinal layers, and there's an increased reflectivity of the inner segment outer segment junction. And the retinal pigmental epithelial changes presented with yellowish hypopigmentation macula sparing the fovea. On OCT, there was an area suggestive of outer lamellar translucency, which was likely to correspond to an area of photoreceptor disruption. And this is a case of traumatic optic neuropathy. This shows thinning of the ganglion cell layer in left eye. And on choroidal rupture, there is a both pattern. There are two patterns are observed. There is first pattern is a forward protrusion of retinal pigment epithelium choriocapillaris with an acute pyramidal dome shape. And second pattern, large disruption of choriocapillaris retinal pigment epithelium, ISOS external limiting membrane with a depression in this area or downward sliding of tissue into this defect. And also in macular hole, there is a partial thickness defect of outer retina at fovea with intact inner layers. And retinal detachment and OCT reveals separation of neurosensory retina from the retinal pigment epithelium. So conclusion, SDOCT proved to be a useful tool in the evaluation of patients with blunt ocular trauma. On OCT, circumpapillary RNFL and ganglion cell complex showed thinning in severe cases, but compared with normal eye, it was statistically not significant. And most of the foveal involvement was in the form of commissuretino. Extrafoveal involvement was in the form of choroidal ruptures and retinal pigment epithelium alterations. So majority of patients had good visual recovery except those with severe foveal damage with poor prognosis, which was accounted by using SDOCT. This OCT is a vital tool in detecting subtle microstructural changes and therefore helps in evaluation and management of posterior segment manifestation following blunt ocular trauma. So these are the references. Thank you.
Okay. You're told about commercial retinol, no? How many patients had commercial retinol in your study?
So those are including foveal. I classified into foveal and extrafoveal. In that, extrafoveal is about 18 patients, and foveal I have got 8 patients.
But foveal patients, what about the visual prognosis in those cases? You followed up the patient, no?
My study, I didn't follow up much of the patient because my study was cross-sectional. So
Normally we expect, the patients to recover better. All these commercial retina patients can recover very well. It's called as otherwise what's it's Berlin edema, you know that.
Berlin's edema, sir.
Why it's called Berlin edema?
If it affects on the macula.
No. Why it's called Berlin edema? Berlin, the
Yeah.
city. Where is it? You know Berlin Wall. That means you know that East Germany, West Germany, like that we have got. In this case, why it's called Berlin edema? You tell correctly. Madam is waiting. Donate. Hey, donate 1,000 rupees, ra. Last chance. Hey, one more chance. Last chance. If you tell why it's called Berlin, she has given me 1,000 rupees now. I'll donate you now itself. You want dollars, $1,000. 1,000 rupees is nothing. So naturally, 1,000. Hello. You don't know. Berlin doctor's name, man. Ophthalmologist name. That fellow found out the problem and he wrote this. That's all. That's why it's called Berlin's edema. It's not because of Berlin and all these things. Steady. Nothing to have connections. It's just for information. Don't worry. Okay.
After how long after the trauma was this OCT done?
Actually, I have done after seeing the patient emergency department. I took the patient
No,
to
no.
the.
The question is how many days after the injury? Because with time OCT findings are going to change.
Sorry, ma'am.
You take carry on.
Ma'am, actually, if the patient is stable, and I took the patient to the OCT at that moment.
Was it an acute injury, chronic injury? What was your patient selection? And this, how is it going to practically transform your management of the trauma?
So by taking OCT, I can find out some subtle microstructural changes. If there is thinning, ganglions and complex thinning or RNFL thinning.
How soon does this thinning occurs?
In some acute cases, I couldn't find out such changes at first. When I done OCT at the first time, but later on, second time I have got some changes in that.
If you say like role of spectral domain OCT in blunt ocular trauma patients, we'll expect you to tell us more about the role of that particular instrumentation in the management of these cases. It's not like just saying like there is hyperreflection of the outer retinal layer. These are all very vague conclusions. You should be more. There is no research question in this study framing. Probably the defect is in the study design. There is no research question. You didn't want to do anything. You just said like this many patients I saw, and that too the numbers are very minimal. Very minimal. The numbers are very minimal. And in those cases, you ended up saying like this and all are seen. I don't see anything dramatic also. There is no RP, RIP, no choroidal rupture. Nothing of that kind also is there. And you are just saying like hyperreflective. That kind of studies will not throw any light in either of the disease process or the instrumentation or the way we manage it. So if you design a study, it should be with the research question in mind, saying like, if I do STOCT in all 100 blunt trauma patients which I see this month, how many prognostication I can do pakka? How many cases I can intervene? Like that, you'll have to have a research question. That probably is the defect. That is why your study has come like so. So next time when you study, think of a hard question, and from there design the study.
Okay, sir.
Okay, and try to find the answer for that.
Okay, sir.